Hello, my dear doctors. So we're going to continue with our MRCP cases. So I'm going to talk a bit about the abdominal station, and today we're going to discuss about a very common case which you can come across in your abdominal station in MRCP cases, that is splenomegaly. Sometimes you may find a patient who had both hepatosplenomegaly, but sometimes lone splenomegaly is the only positive findings. So if you come across this patient, so I have made this very brief video to tell you about all the information and all the findings that you need for to go through your MRCP basis abdominal station. So suppose if you come across a patient who has only lone splenomegaly, so in this case it is important that you do not present the findings in the order in which you did or did not elicit them, as by doing this you may lose time presenting many negative findings. So instead of that, if the only positive finding is splenomegaly, you can just say the patient who presents with abdominal pain has splenomegaly on abdominal palpation with the splenic tip lying whatever it is, 5 centimeter, 10 centimeter below the costal margin. Let's talk a few causes about the splenomegaly. Once we have found the splenomegaly in a patient, and I'm sure you all know how to palpate the spleen. Normally you have to start on the right iliac fossa and you move upward by asking the patient to deep breath until you can feel the spleen tip. So causes are important because once you have all the causes in your mind, then you can look for other positive findings which can lead you to the diagnosis of the splenomegaly. Like splenomegaly can happen with hematological malignancies. It can also happen with anemia, normally called hemolytic anemia. Sometimes it can be related to rheumatoid arthritis. We know that is Felty syndrome, or it can be related to the portal hypertension. So even though if you are in abdominal station and you find the rheumatoid hands, then you can be quite sure that patient may have a splenomegaly because it is related to the rheumatoid arthritis. And similarly with the portal hypertension, it's normally because of the cirrhosis of the liver, and you'll find the peripheral stigmata of the chronic liver disease, and in that case you may find only splenomegaly there because liver may be shrunken because of the cirrhosis. So in that case also, if you find any peripheral findings, you can be positive about the cause of the splenomegaly, which will help in your presentation. So obviously once we are doing this, so we're going to look for the signs, to look for any underlying cause. I already talked a bit about it. Let's talk a bit more. Let's suppose you're thinking about hematological malignancy, then you're looking for anemia, lymphadenopathy, or cachexia, obviously portal hypertension, evidence of CLD, and if you're suspecting hemolytic anemia, patient has jaundice, then you will start thinking about the hemolytic anemias that is causing splenomegaly. The differential diagnosis for lone splenomegaly, well, it is quite broad, but just keep in mind few of the causes, like it can happen with infections like brucella, salmonella, endocarditis, so on. Can be because of the storage diseases like amyloidosis and sarcoidosis, or it can be because of the autoimmune disease like SLE. Okay, so once you just keep everything in mind because it will help with your presentation. So let's talk about the workup. So how you work up the patient who has presented with the lone splenomegaly. Obviously, we're going to start with the history. We want to talk about the travel history, sexual history, and any constitutional symptoms: fever, weight loss, lymph nodes enlarged, night sweats, which can lead to some cause for the splenomegaly. Do some blood investigations. We want to do the abdominal ultrasound to confirm or find a splenomegaly, and axial imaging as well. Okay, so that was all about your examination. Now, how you will present the case. So, first of all, you should um, tell the examiner that the diagnosis is splenomegaly and you are able to um, find the splenomegaly, and it is splenomegaly without hepatomegaly. If it is hepatomegaly, obviously you're going to say that. Then, once you have uh, get the message across the examiner that you were able to identify the splenomegaly, then we'll talk about the negatives, important negatives. Like we say, there is no evidence of anemia or jaundice, um, which reducing the possibility of either myeloproliferative disease disorders or hemolytic anemia. There is no stigmata of chronic liver disease or portal hypertension, and there are no signs of rheumatoid arthritis or any other connective tissue disease. So these are the important negatives which you must mention, because then the examiner will be knowing that you're looking for these causes for the splenomegaly. If there's any lymph node enlarged, you can say the lymphadenopathy positive, like I came across a patient with splenomegaly with enlarged lymph nodes. So I was thinking about the possible underlying lymphoproliferative disorders such as chronic lymphocytic leukemia. Okay, so this is how your presentation, this is your scheme of the presentation. First of all, you talk about splenomegaly, then important negatives, and if any positive findings, just mention that. And then you will not stop here. You'll say, I'll complete my examination by taking a detailed history, particularly travel history. I'll ask about any constitution symptoms, any symptoms of infections or liver disease. And moving on, I'd like to request an ultrasonography abdomen to confirm my findings and do some blood tests to look for the cause of the splenomegaly. So this is how your presentation should be, and please keep in mind, practice it and do it 2-3 times so that if you come across splenomegaly, a case of splenomegaly, there should be no confusion. Once you're done the presentation, obviously the examiner will ask you a few questions. Normally these questions are straightforward in the case of splenomegaly, and I must tell you the abdominal station is actually the easiest station in the basis examination because there are not many cases, and usually if you have palpated the spleen, it will be quite easy for you, and the examination and the questions, they are quite predictable. So examiner must know how you investigate the patient. We have talked a bit about our investigations already. Let's elaborate a bit more. First of all, I like to do some blood tests. What blood tests we want to do? We'll move on and tell about, I want to do the full blood count. I want to do the peripheral blood film. Full blood count, maybe I'm looking for any polycythemia, maybe looking for any neutrophilia. I like to do serum LDH, beta microglobulin, because I'm thinking about amyloidosis. We want to do the autoimmune profile. In autoimmune profile, you like to do the all the anti-nuclear antibodies. You want to do the um, ENA. You want to do the rheumatoid factor, and also you want to do the HIV. So when you're talking about how we investigate the patient, please divide them into different groups, and then it will be quite easy for you. Like first of all, we talk about the blood tests, okay, and after the blood tests, we're going to talk a bit about the imaging. So we're going to talk about the blood test first, then the second one, imaging. We want to do abdominal ultrasonography and axial imaging, and then the others tests. Others tests include, like if you find a lymph node, we want to do the lymph node biopsy or a bone marrow biopsy. So how will you manage the patient's splenomegaly? Obviously, you want to confirm the diagnosis of splenomegaly. We look for any obvious causes. We do some investigations, and then we have to refer to the relevant specialty. Okay, then this is a quite common questions which comes up in the viva of this splenomegaly case, that when we consider splenectomy. So there normally the splenectomy actually it should be avoided because it's a high risk operation and it is rarely curative. So generally the splenectomy is sometimes indicated in cases of idiopathic thrombocytopenic purpura. It can be done in sickle cell disease, hemolytic anemia, or hereditary spherocytosis. And there could be other questions also, like once you've done the splenectomy, what's the danger? Because once you've done the splenectomy, the patient is prone for the encapsulated infection in encapsulated organisms. So patient have to be on the prophylactic penicillin. So that's it, my dear doctor, for the lone splenomegaly. Hopefully this brief presentation will help you and give you some confidence in getting over the case of the splenomegaly Mrcp patient. Thank you very much, and goodbye till my next presentation.